الصوت. نرحب بحضراتكم مرة تانية مع الندوة إن شاء الله الثالثة عشر بعنوان التحليل البيوميكانيكي وقرار العودة إلى ممارسة الرياضة بعد الإصابة، الاعتبارات والمحاذير. هيكون متواجد معانا ومشرفنا إن شاء الله رئيس الندوة الأستاذ الدكتور بسمان عبد الجبار، أستاذ البيوميكانيك الرياضي وأستاذ زائر بجامعة أدنبرا والجامعة الهاشمية الأردنية. المتحدث الدكتور كاثرين دانيالز جامعة مانشستر المملكة المتحدة. مقرر الندوة الأستاذ الدكتور إيهاب أحمد منصور، أستاذ فسيولوجيا الرياضة كلية التربية الرياضية جامعة المنصورة، ولكن بنعتذر لعدم تواجده نظرا لوفاة الأستاذ الدكتور محمد الشحات عميد كلية التربية الرياضية الأسبق جامعة المنصورة. خالص العزاء طبعا لأسرة كلية التربية الرياضية بالمنصورة وجميع كليات التربية الرياضية بمصر والوطن العربي، ونسأل الله العظيم أن يسكنه فسيح جناته ويلهم أهله وذويه الصبر والسدوان. تفضل دكتور بسمة.
مساء الخير، السلام عليكم جميعا ورحمة الله وبركاته.
وعليكم السلام.
إن شاء الله يكون الصوت واضح والفيديو واضح دكتوري العزيز. في البداية الحقيقة نتشرف في أن نكون ضمن المؤتمر.
نعم بسمان. برضو بنحب ننوه، أنا آسف للمقاطعة، بنحب ننوه إن شاء الله في ترجمة معانا الدكتورة آمنة مرقسي والدكتورة ريان جمعون.
نتشرف بالانتربترز with us. It's okay. وأنا راح تكون مداخلاتي فقط من أجل قد تكون هنالك some scientific terms about biomechanics. I will help with these topics if they allow me. وأتشرف بوجود المترجمين. الحقيقة لي الشرف في أن أكون ضمن المؤتمر الذي تقيمه جامعة الإسكندرية، المؤتمر الافتراضي من الرياضة والصحة، أمن قومي عربي أفريقي. نرحب بالدكتورة كاثرين دانيالز from Manchester University. فتتفضل المترجمة أن ترحب بها، وبعدين أقدم عنوان الندوة اللي هو التحليل البيوميكانيكي وقرار العودة إلى ممارسة الرياضة بعد الإصابة، الاعتبارات والمحاذير. The titles of this lectures will be biomechanical analysis and the decision of return to sports activity after infected, concentration and cautions. تفضلي الأستاذة المترجمة. رحبي بالدكتورة كاثرين دانيالز لكي تبدأ محاضرتها. أعتقد راح نكون بدون مقرر، صحيح دكتور سعيد؟
Greetings, Dr. Catherine Daniel. My name is Marxi Amina, and I will be your translator. And I may have to interrupt you in order to translate to the participants. So we welcome you to start your symposium.
Brilliant. Thank you very much. Let me just share my screen.
Okay, doctor, take your time.
Great. So hopefully you can see my screen now, yes?
Yes, clear.
Brilliant. Well, thank you very much for the invitation to speak. I am a senior lecturer at Manchester.
Doctor, yes? I'm sorry, we cannot see the screen.
Okay. Got it now?
Yes.
Yes, it's clear.
Great, thank you very much. So as I said, I'm at Manchester Metropolitan University in the UK, and I also acknowledge Sports Surgery Clinic in Ireland here too for my talk, because I was based there until 9 months ago, and this work was done there or in collaboration with the clinic. I'm going to talk about methodological considerations in using biomechanical analysis to guide and inform return to sport decision-making after musculoskeletal injury. For the purpose of this presentation, I'm going to focus mainly on analysing change of direction manoeuvres after ACL reconstruction, but the general principles are relevant to any movement analysis using these types of techniques that I'm going to discuss. So anterior cruciate ligament rupture, ACL rupture, is a really common and it's a severe sports-related knee injury caused by excessive acute load on the ligament. It often occurs in multi-directional sports, and 70% of these ruptures are actually non-contact. Analysis of injury events suggests that the moment of rupture is early in stance phase with the leg in an extended position, which corresponds to cadaveric studies showing that the greatest load on the ligament is generated by an external knee abduction torque or moment in the presence of an anterior shear force with a relatively extended knee. So in the context of sporting maneuvers, that's generally movements like landing, turning quickly, or decelerating. The most common treatment in athletes looking to go back to multi-directional sport is surgical reconstruction of the ligament, most commonly using either a bone patella tendon bone or a hamstrings tendon autograft from the same leg. There's then an extensive rehabilitation time, so 6 to 12 months, sometimes longer than 12 months before these athletes are back playing and performing. So that's an extended time period. However, the problem is that there's up to a 25% re-injury rate, depending on, the study and the follow-up rate. There are very different numbers on this. So there's a strong research need for a better understanding of how to monitor rehab, how to identify and target risk factors, and how to make decisions as to when athletes return to sport and return to the next level of kind of the return to play process. So research is really focused on what we should be measuring to monitor rehab and inform this decision making to maximize outcomes for the athlete and to minimize the risk of re-injury. There are some conflicting findings in the literature, but it seems clear overall that no single test can be used on its own to guide these decisions, and that testing batteries should include assessment of both task performance, so how fast you can do something, how far you can jump, and the actual quality of the movement. Passing performance tests, like typically greater than 90% symmetry of the distance that you cover in a hopping task, for example, have been associated with successful outcomes. But many studies, including studies from our lab, have highlighted that athletes can achieve symmetrical performance in terms of distance, jump distance, jump height, time to complete an agility task, but with big asymmetries in the actual joint level mechanics and work distribution. So we have to measure these to get a full picture of what's going on. It's also become clear that just symmetry isn't good enough as a measure, because we can see deterioration on the non-injured side after surgery and rehab as well. So an athlete that's equally bad on both legs can't really be considered to be successfully rehabilitated. So we have to look at the actual values, not just the symmetries. Now, one of the tasks that's received sort of relatively limited focus in the context of return to sport testing compared to movements like vertical and horizontal jumps is change of direction. So this is despite the fact that change of direction is the most common mechanism of non-contact ACL injury. It's a more ecologically valid task. It's more relevant to actual sporting demands on the field than the type of task that's typically analysed, and it's a really important metric for performance in multi-directional sport. One of the big challenges in incorporating this movement into testing batteries is that its biomechanical analysis is particularly susceptible to high variability and errors as a result of methodological variation. So that's both in how we handle the data that we collect and also in how the athletes perform the task, how we control the task. So these sources of variation and their implications for research and for clinical athlete testing will be kind of the focus of the rest of this presentation.
Excuse me, Dr. Catherine Daniel.
Yeah.
We are now going to translate to the participants.
Perfect.
Thank you. إذن عرضت الدكتورة كاثرين دانيل من خلال مداخلتها موضوعا جدا مهم تمحور حول ماهية الاعتبارات المنهجية في استخدام نقول التحليل الميكانيكي الحيوي لاتخاذ قرار العودة إلى ممارسة الرياضة بعد حدوث الإصابة، حيث ركزت في دراستها هذه على الرباط الصليبي الأمامي أو ACL، وهو واحد من بين الأربطة الرئيسية على مستوى الركبة. تشيع حدوث الإصابة فيه خصوصا أثناء أو خلال ممارسة الرياضة كالتوقف المفاجئ أو التغيير في الاتجاه، وهذا ما نجده وما نلاحظه عادة في رياضات مختلفة ككرة السلة، كرة القدم، التزلج وغيرها. كما تذكر كذلك الدكتورة في مجال علاج رباط ACL إثر تمزقه عند الرياضيين بالتدخل الجراحي السريع، تليه بعد ذلك فترة تأهيل في مدة ما بين 6 إلى 12 شهرا. كما تم الإبلاغ عن معدلات الإصابة على مستوى هذا الرباط ب25%، وهنا تظهر أهمية تحليل مستوى الإصابة لتقييم الرياضيين. You may proceed. Your sympathy, and Dr. Catherine.
Thank you very much. So I just want to be clear about exactly what I mean by change of direction here. So this is a turning maneuver that's performed while running, typically at maximum effort, certainly in a sports context, in which the athlete has to change the direction that they're traveling in and also rotate the body to face in the direction of the new direction of travel, and by pushing off the outside leg to make the turn. So here is a video of the movement as tested in the sports surgery clinic assessment lab. So the athlete is cued to complete the task as fast as possible from one timing gate to the next timing gate, and the gates are arranged so that the total change of angle is 90 degrees. There are 2 force platforms in front of the red mannequin, so we can capture ground reaction forces as well as movement kinematics for the change of direction step. And now you could probably see in the video that the athlete has markers stuck to their body, which are being recorded by optical motion capture cameras in the lab. And because I know this is a mixed audience, I'm just going to do a quick overview of how optical motion capture actually works to calculate our variables we're interested in, and just so everyone understands how the data were collected, because this is important when you start talking about methods. So briefly, retroreflective markers are placed on predefined anatomical landmarks on the body, and the positions of those markers are captured by cameras that shine out infrared light. The light is then reflected back off the markers and recorded by the camera, which allows a 2-dimensional image like the one on the right to be generated. We have multiple cameras with multiple viewpoints in a calibrated space, so all the individual 2D images can be combined to form a 3-dimensional reconstruction of each marker's position in space at sub-millimeter levels of accuracy, with hundreds of frames per second. We typically capture at 200 or 300 frames a second for these movements. The last steps involve attaching labels to the individual markers so they can be tracked through space. And finally, and really importantly, the markers are used to define the positions and the orientations of rigid linked segments that make up the body. So, for example, a pelvis segment and a thigh segment. Once we have defined segments, we can then calculate the angles between them in all 3 planes. So that's flexion extension in the sagittal plane, abduction adduction in the frontal plane, and internal external rotation in the transverse plane. There are different ways of doing this, but the model we use to link marker placements to segment rotations and positions is called the conventional gate model, and it's a common model that's used in clinical research. With the addition of force plate data, we can then also calculate the turning forces or the moments around a joint. I'm going to mention the knee abduction moment and angle in this talk quite a bit, because as I said earlier, it's associated with load on the ACL, and it's been suggested to be a risk factor for primary and secondary injury. These are the 3 major methodological considerations I'm going to talk about, and they're major considerations for analysis of change of direction, or indeed of analysis of any kind of movement. If you're interested in movement research or in biomechanical assessment of athletes, it's really important to understand the role of all 3 of these features in the accuracy and the reliability of the data you collect or read about, and the way that you interpret it. So marker placement. So inaccurate placement of these markers is a key source of error to consider when you're analysing any motion capture biomechanical data. As I said before, the joint angles and the moments are calculated from segments that are defined by markers placed on specific landmarks. So if the position of the marker is wrong, then the calculated angles and the moments will also be wrong. And the problem is that intra-observer reliability in the identification of these landmarks through palpation ranges between 5 and 21 millimeters. This has been published, and the intra-observer between tester variability can be 12 to 25 millimeters. We already know that errors of this extent can significantly affect the calculation of kinematic parameters in walking gait, but we also know that the effect of this error is dependent on all the joint angles, so we can't necessarily assume that those results translate to change of direction research, and they don't tell us quantitatively, you know, how concerned we should be about this variability, when it matters and when it doesn't. So the purpose of these first studies were therefore to ask the questions: how sensitive are change of direction, lower limb kinematics and knee moments to marker placement? And what are the implications for analysing and interpreting movement after ACL reconstruction?
Excuse me, doctor.
Yep.
We are now going to translate to the participants. Thank you. إذا كما وضحت الدكتورة كاثرين أن تقنية تصوير أو التقاط الحركة بالاعتماد على مجموعة بيانات أو معطيات القوة لتسجيل حركة الجسم إضافة إلى كم القوى من خلال تتبع المواقع أو مواقع النقاط المنعكسة على المناطق التشريحية في جسم الرياضي. إذا تستخدم هذه النقاط لتحديد مواضع واتجاهات أجزاء إضافة ونمذجة الجسم كالحوض، الفخذ، وحساب الزاوية بينهما نقول من خلال تقنية محاكاة ونمذجة المشي عند الإنسان. وتشير الدكتورة إلى أن عدة دراسات قد أظهرت التي أجرتها الباحثة أن المتغيرات الحركية الأمامية والمستعرضة حساسة لتغير موضع العلامة، لذلك يجب القيام بتفسيرها بحذر. حسب الدكتورة فإن نموذج محاكاة المشي يعمل على مبدأ أن جميع أجزاء الجسم مرتبطة ببعضها البعض، بالتالي تتمتع المقاطع والمفاصل ب3 درجات من إمكانية الدوران. هذا ما يؤكد أن للباحثين والممارسين في حاجة إلى النظر بعناية لاختيار النموذج الملائم للقيام بالتحليل الميكانيكي المناسب. Thank you, Doctor. You may proceed, your symposium.
Thank you. This work then was led by Kieran McFadden, who's a PhD student based in Dublin. He ran 2 studies, both of which used simulations to test the effect of displacing the thigh, the knee, and the shank marker anteriorly and posteriorly. You can see those markers on the image on the left. They were chosen because A, they're commonly misplaced, and B, they have the greatest effect on calculated knee angles and moments, so they're very relevant in the context of ACL injury. In the first study, we wanted to find out which kinematic and kinetic variables were most sensitive to displacement of these markers during a change of direction stance phase. And we did it by applying systematic simulated displacements of one marker at a time at 5 millimeter intervals, both anteriorly and posteriorly. And amongst other things, we analysed how far you had to move an individual marker to create a statistically significant change in the calculated angle or moment, on the basis that that's the point at which you might alter your interpretation of the results that you generate in a study. So these are the results, and you don't have to be able to read it because the impression is just in the shape of it, although you can look at the numbers if you want. This line down the middle represents the no displacement condition, and as we move out to the left and out to the right, you can see the results as the markers are moved 5, 10, 15, 20 and 25 millimeters from their original positions. So empty white boxes mean that there was no significant difference for any of stance phase compared to the no displacement results. And as the colours get darker, it means a greater and greater percentage of stance phase was affected as you move outward from the green line, and the numbers in the boxes just tell you exactly what those parts of stance phase were. The top panel shows the results when the thigh marker is displaced, the middle panel when the knee marker is displaced, and the bottom marker when the shank marker was displaced. And then the different joint variables are listed down the left-hand side. We will focus on the peak knee abduction moment, which I've highlighted here. You can see from the top panel that this variable is pretty insensitive to high marker placement error across this range from the thigh marker. From the middle panel, that knee marker placement only starts to have an effect when the error is greater than 15 millimeters. But in the bottom panel, you can see that errors of greater than even 5 millimeters in shank marker placement cause significant differences in the values that we ultimately calculate. And remember that that's smaller than the published variability ranges for the placement of those markers in experienced experimenters. So we can see that marker placement is potentially going to be significantly affecting the conclusions that we draw from our data. And now that first study we systematically offset one marker at a time by a predefined distance. And what we're interested in the second study is to basically simulate the kind of error that you would get, or the kind of pattern you would see in the real world, by repeatedly generating virtual sets of marker positions with a distribution of marker displacements applied to them, and looking at the distribution of the overall results for the calculated variables. For each simulation, the individual marker placement error for each lower limb marker was drawn from a distribution based on the published error ranges for each marker. And then the angle and the moment variables were calculated based on the new marker positions with the errors added repeatedly. And these figures show the knee abduction moment results. The graph on the left is a histogram that shows the distribution of the amount of interlimb asymmetry that we would expect to find purely because of marker placement error if the true asymmetry in the participants' movement was 0, so perfect symmetry. And we can use that distribution to identify the minimum amount of asymmetry or change in asymmetry, if we're tracking a single athlete longitudinally, for example, that we would need in order to conclude with 95% confidence that we had identified real asymmetry or a true effect, rather than just noise due to variability in marker placement. And as you can see from the graph on the right, that threshold for this variable is about 0.5 Newton meters per kilogram. And that's equivalent to a 50 to 100% change or difference in the magnitude of that knee abduction moment. So experimentally, or working with athletes, if you're looking for or you're expecting a smaller change than that, you probably can't detect it reliably using this model. So the take home then from the marker placement work so far is that it's really important to be aware of the precision of the measurement, particularly for evaluating individual athletes or sessions. And frontal plane and transverse plane kinematic and kinetic variables are particularly sensitive to marker placement variability in this movement, and so they should be interpreted with caution. The next consideration then is the selection of the biomechanical model. So I said earlier that these analyses were done using the conventional gait model, which uses the assumption that the segments are all linked to each other, and therefore the segments and the joints have 3 degrees of freedom. They can flex and extend, they can abduct and adduct, and they can internally and externally rotate. Now, there are other modeling approaches that don't make that assumption, and they also allow translation at a joint. So one segment is allowed in the model to shift relative to the other segment, and they're called 6 degree of freedom models. Now, we know that there's a small amount of translation at the knee joint as it flexes, so this can be a better representation of reality, but these models can give anatomically unfeasible results unless you put additional constraints on them because of effects like skin movement. We wanted to know what the effect of model choice was on the joint angle and moment variables that we've been looking at and that we're interested in for monitoring athletes after ACL injury. So if an athlete was identified as having a particularly large and potentially high risk knee abduction angle using one model, for example, would they also be identified as having a large knee abduction angle using a different model? And this is important for understanding the effects of model assumptions on our results, but also for being able to interpret the existing literature. There are lots of conflicting findings out there, and differences in model choice might potentially explain some of them. This work was done by Kirsty Scott, led by Kirsty Scott, who was a research assistant at the time, and she's now a PhD student at the University of Sheffield. She created a marker set that could be used for both a 6 degree of freedom and a 3 degree of freedom model, and collected data from 23 participants who were about 9 months after ACL reconstruction surgery. She then applied the models and calculated joint angle and moment variables using each model separately, and investigated the relationship between the two sets of results that she ended up with. So this is what she found. These data are actually from a bilateral vertical drop jump, because we haven't published the change of direction data yet, but the pattern that we saw was exactly the same across movements, basically. And these plots are of knee angles. There's flexion extension on the left, abduction, adduction in the middle, and internal external rotation on the right. The peak value calculated using a 6 degree of freedom model is plotted on the x-axis, and the 3 degree of freedom conventional gait model is on the y-axis. And what you'll see is that there's a strong relationship between the results from the two models in the sagittal plane on the left, but the relationship is very weak and actually negative for the frontal plane in the middle. And on the transverse plane on the right, it's also not a super strong relationship, although there's a relationship there. So what this means is that you have to consider which models to use and its assumptions very carefully as soon as you move outside analysing the sagittal plane in your own work, and also that we should be cautious comparing findings directly from studies that use different models, because not just the magnitudes of the calculated outcome measures can be different, but also the rankings, the relationships between them. The last methodological point then that I'm going to discuss is task modulation. So this is a major issue in change of direction research, and I think it's one of the main reasons that we haven't been able to exploit this movement reliably in testing batteries more than we have. So what I'm talking about here is the scope of the participant to actually alter the nature and the mechanical demands of the specified test task to make it easier to do on the injured side, so that differences in joint level movement strategy that we analyze end up just reflecting differences in how the task was performed, rather than differences in how an identical task was performed on an injured and a non-injured limb, for example. So when an athlete performs a change of direction maneuver, they're able to regulate their own approach and exit speed and angle to a greater or lesser degree. So I'll show you the task here again, hopefully, yeah. The athlete is cued when they're turning in exactly the same way when they're turning off the left leg, the injured leg, and the right leg, the non-injured leg. And the cues are to run as fast as they can from the first gate to the second gate, and to complete the 90-degree turn. Okay, so that leaves us then, given those cues, there are then 3 major kind of task level components that the athlete could modify to alter the demand of the task on the operated limb. So there's the change in the heading angle of the body center of mass during the step, the amount of rotation of the body, and the approach speed. And all of those factors we already know from previous work have their own independent effect on knee joint angles and loads. So therefore, our question was, are systematic asymmetries in change of direction task modulation observed after ACL reconstruction? And do these asymmetries affect our interpretation of the joint level asymmetries? Do they matter? So this study was done in a cohort of male multi-directional field sports athletes who were tested 8 to 10 months after their reconstruction surgery, and they performed the change of direction maneuver cutting from their operated leg and from their non-operated leg. So the first result was, although the approach run-in obviously required both legs, regardless of which way they were going to turn. They ran and they reached the force plate more slowly when they were going to be turning from their operated than from their non-operated leg. And we also saw this same pattern in a similar reactive change of direction maneuver in a separate study. So we see differences in speed between the two legs. For turning differences, we investigated both the body and the velocity vector angle at initial contact at the onset of the change of direction stance step, and also the total change in those angles from the beginning to the end of stance phase. So by how much did they rotate, how much did they change the direction that they were traveling in, given that they were told to do that it was a 90-degree task and the timing gates were laid out at 90 degrees.
Excuse me, doctor.
Yep.
Yeah, we are now going to translate to the participants, please. Thank you. إذا باختصار فقط لضيق الوقت كما نعلم، أشارت الدكتورة في مداخلتها إلى أن المشكلة الرئيسية هنا تكمن في أبحاث COD أو Changes of Direction التي تتطلب فيها الحركة تغيير الاتجاه بشكل مفاجئ، حيث أنها تندد أن أحد الأسباب الرئيسية لعدم تمكن أو لاستصعاب الأبحاث من خلال استغلال هذه الحركة بقوة في بطاريات الاختبار للرياضيين. وكمثال تعطيه الباحثة عندما يقوم رياضي ما حسب الفيديو الذي قد أوضحته في مداخلتها بأداء COD بجهد 90 درجة بعد 9 أشهر من إعادة تأهيل ACL أو الرباط الصليبي الأمامي، وجدت أن هنالك اختلافات منهجية في زوايا COD المقاسة خلال التمرين. بالتالي فالرياضي هنا يتحول بزاوية ضحلة عند الالتفاف بالساق التي خضعت للجراحة. Dr. Catherine, you may proceed with your symposium.
Thank you very much. So what we found from those studies was that there were systematic differences in both body rotation angles and heading angles at initial contact, and also differences in how much they change through stance between turning off the operated leg and turning from the non-operated leg. So on the operated leg, the body was less rotated towards the new direction of travel at initial contact, and with a heading angle more oriented towards the new intended direction of travel. During stance, there was less body rotation and less heading angle change, so the participants were effectively making the task easier for themselves, and by cheating and doing a less sharp turn than on the operated leg than they did on the non-operated leg. You can also see on the graph on the right that for both legs, there was a subject-specific trade-off between heading angle at initial contact and the change in heading angle during stance. So some participants started their turn before the change of direction step slightly in order to make their life easier on the force plate. All of these variables represent modulation of the way the task was executed that influences the joint level variables that we calculate to investigate movement strategy. So what this means is that when we identify differences in, for example, knee abduction moment between limbs or between participant groups or between injured and non-injured cohorts, we should make sure that we understand whether these differences are differences in the task that's being performed or whether they're differences in the mechanics of an identical task being performed on the two limbs. So we've got work ongoing at the moment that has shown that these systematic differences are big enough to actually influence what we see and the way we might interpret the results when we compare mechanics. So I'd say that it's really important, again, to measure and to control for this variation, which can be done to make sure you're interpreting results appropriately and understand what is being reflected in the joint level data that is seen. So in conclusion then, I talked about three major methodological considerations that are currently affecting our ability to leverage change of direction tasks in understanding musculoskeletal injury biomechanics: marker placement, model selection, and task modulation. And by understanding and controlling their effects on our own data and bearing them in mind when we're interpreting previous research findings, I think we can make really great strides forward in using this task to monitor individual athletes and to study risk factors and consequences of injury. So thank you very much, and thank you to these people without whom none of it would have been able to happen.
Thank you, Dr. Catherine Daniels, for granting us some of your precious time and for the enlightening knowledge you have shared with us today. I'm going to translate the rest of your symposium.
Thank you.
وفي الختام تنوه الدكتورة إلى 3 اعتبارات منهجية رئيسية تؤثر على قدرتنا في الاستفادة من مهام COD Changes of Direction وفي فهم الميكانيكية الحيوية لإصابة العضلات والعظام وكذلك لدراسة عوامل الخطر وعواقب الإصابة. وشكرا.
شكرا للدكتورة كاثرين. Thank you very much, Catherine, about wonderful presentation. إذا في أسئلة, we are waiting for the question from our colleagues. Okay.
Great, thank you.
Okay, we have one question from, let's say from
دكتور أمال.
from دكتور أمال. تفضلي دكتورة أمل. عفوا دكتورة أمل. تفضلي. افتحي المايك يا دكتورة أمل. افتحي المايك يا دكتورة أمل.
ايوه، السلام عليكم.
اهلا وسهلا يا هلا.
اهلا بحضرتك وكل القائمين على المؤتمر العظيم. انا بشكر الدكتوره دانيالا على المحاضره القيمه بتاعتها. الحقيقه سؤالي ان الدكتوره اتكلمت عن نماذج بايوميكانيكيه لاتخاذ القرار في العوده بعد الاصابه. انا بسال الدكتوره هل احنا ممكن ناخد تحليل اللي هي الجيت اناليسيز لخطوه المشي بتعتبر كمؤشر لان احنا ممكن نتخذ القرار في عوده اللاعب المصاب وبعد التاهيل، يعني بعد التاهيلي، وايه هي اكتر المتغيرات اللي ممكن ان احنا نعتبرها بالنسبه لنا كمحكات بايوميكانيكيه تديني مؤشر صادق للعودة بعد الإصابة.
شكرا دكتورة أمل. أيوة، تحب المترجمة الأستاذة المترجمة تترجم السؤال؟ تفضلي.
Dr. Catherine, the question of Dr. Amal is as follows. Can we apply analysis on walking as a telltale sign that the athlete has completely healed after the rehabilitation? And what are the signs that the athlete shows?
Walking in itself is generally, if the athlete is asymmetrical in walking, then they're very definitely not fully rehabilitated. But what we tend to do is to look at more demanding sport-specific tasks and a variety of them to see whether we have, we test change of direction and we test jumping and landing. So we're putting greater loads on the joints and structures in order to kind of to probe the movement in a more demanding way, to more closely replicate the kind of demands that they're going to actually see on the sports field. So just by looking at walking, definitely no. If we then say, is symmetry a good measure? Symmetry is a good starting point. So I think you wouldn't consider somebody to be fully rehabilitated until they were symmetrical. It's necessary, but it's not sufficient. Those values also need to be up at a level either that matches, if you've got baseline data from athletes, that's brilliant, because you can compare them to where they were before the injury, or otherwise we would compare to healthy controls at the same level to see whether the magnitudes of the values and the performance that they're producing is at a level that we think is a reasonable threshold to return to play.
Thank you very much, Doctor. وكما قالت الدكتورة كاثرين، إنه يمكننا استخدام التوازن كدليل على أن الرياضي قد استأنف استشفاءه، وكذلك من خلال إجراء التجارب. وشكرا.
Okay, Catherine, I think there is no more question, but I want to ask you something about your presentation. If our translator allow me to speak about that. Anyway, as we know, we have many degrees of the ACL tears. So my question is, did you take this in your consideration of this presentation or your research? We have full tears, we have partial tears, and the tears happen in these ligaments. I think it is very bad injuries to the athletics. But just allow me to translate the question to my colleagues. أنا الحقيقة سألت أنه هنالك درجات من الإصابة، أي من التمزق. هنالك تمزق كلي وهنالك تمزق جزئي. فهل أنه تم اتخاذ أو أخذ ذلك بنظر الاعتبار عند إجراء هذا البحث؟ Okay, you can go, Catherine. Thank you very much.
Thank you. So all of the work that I've presented was done on athletes that had a full tear and then a surgical reconstruction that was basically a replacement of the ligament.
Okay.
So I agree with you that there's very definitely, that there's been a lack of focus really in this context on what the best way to handle partial tears are. So yeah, I think it's a really good point, but for this presentation, it was all full tears and then full replacement of the ligament.
Thank you very much. This is a very good answer. And I think my question is a future ideas for your research. Thank you very much. طبعا هي أجرت البحث على كاثرين أجرت البحث على التمزق الكلي لهذا الرباط، وممكن المستقبل أن تجري البحث على الحالات الأخرى. أعتقد there is no more questions even on the chat. لا توجد أسئلة أخرى حتى على الشات. Thank you, Catherine, for your wonderful presentation. Thank you for our translator or interpreter with us. I appreciate their effort with us. شكرا دكتور محمد على دعوتنا لحضور هذا المؤتمر. Nice to meet you, Catherine.
Thank you very much. Thank you very much for the invitation to speak. Thank you to everyone for listening, and thank you to the translator.